Have you ever found yourself trying to stick to a new habit? Like, consistently hitting the gym or maybe trying a new diet?
Oh, absolutely.
Or perhaps you had a doctor give you specific recommendations you knew were good for you. You start with, the best intentions,
To
right?
motivated.
Yeah, you're motivated, you're convinced it's the right path, but then, well, life happens. Or maybe something else shifts and suddenly that strong intention just seems to fade.
It can be incredibly difficult to maintain, even with all the willpower in the world.
Yeah, I've definitely been there trying to learn a new language.
It's a pretty universal challenge, I think, and it becomes profoundly critical in healthcare, especially for people managing chronic long-term conditions. The stakes are just so much higher there.
Exactly. And that really brings us to the core question for this deep dive. Why is it so incredibly hard for people to adhere to medical treatment, particularly when they're dealing with a chronic illness?
It's a complex puzzle.
To start unraveling this, we're diving into a fascinating meta-analysis. It's by Rich, Brandis, Milan, and Hager from 2015, and it's titled Theory of Planned Behavior and Adherence in Chronic Illness, a meta-analysis.
Right, and for anyone maybe not familiar, a meta-analysis is, well, it's a really powerful research approach.
How does it work exactly?
Instead of doing new experiments, it systematically combines and analyzes data from lots of existing studies on the same topic. Think of it like taking, I don't know, dozens, maybe hundreds of individual puzzle pieces from different researchers
Okay.
and fitting them together to see the larger picture. You get a much clearer, more robust view than any single study could offer on its own.
Got it. So our mission today is to really pull out the most important insights from this pretty robust scientific research. We're going to break down the theory of planned behavior, which is, well, hugely influential. Then we'll see how well it actually explains treatment adherence, specifically in chronic illness contexts.
And ultimately, what does it all mean for actually improving patient outcomes? That's the goal.
Exactly. Consider this your shortcut to getting up to speed on a complex and frankly often baffling aspect of human health behavior.
Let's dive in.
So before we even tackle the theory itself, maybe we should be crystal clear on what adherence really means. Because it sounds like it's more than just taking your meds, right?
Yeah, absolutely. The World Health Organization defines adherence as the extent to which a person's behavior taking medication, following a diet, and/or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider.
Okay, so it's about actively participating, matching your actions to the advice.
Precisely. It's about that active partnership in their own care plan.
That sounds like, well, a fundamental part of healthcare.
Yeah.
But how widespread is the problem of non-adherence? Is it really that common?
You'd think it would be straightforward, wouldn't you? But the reality is shockingly different. The problem of poor adherence is incredibly widespread. It's really well documented.
How bad are we talking?
We're talking about a staggering statistic. Around 50% of patients with a chronic condition do not adhere to their treatment recommendations.
50%. Half.
Half of all patients, yeah.
Wow. That's not just a minor hiccup in someone's care plan. What are the immediate consequences of that level of non-adherence?
Well, the implications are pretty dire. Non-adherence leads to significant mortality, increased morbidity, which basically means more illness and suffering and substantial financial costs within healthcare systems everywhere.
A huge burden then.
A huge burden, definitely, both on individuals who aren't getting the benefits of treatment and on society struggling with health costs. And this is precisely why researchers emphasize the need for appropriate theoretical frameworks.
Okay, makes sense.
It's not enough to just identify what predicts non-adherence. We need theories to guide how we actually develop effective interventions. They give us a structured way to understand and hopefully influence these really complex health behaviors.
Yeah. Okay, let's unpack this theory then. The theory of planned behavior, or TPB. You hear about it a lot. It's described as one of the most widely applied models for predicting intentions and behaviors.
It really is a cornerstone in health psychology.
So, if intention is the key thing it predicts, what are the main pillars that, according to TPB, build up that intention?
Okay, so at its core, TPB suggests that a person's intention to perform a behavior is the most direct or proximal predictor of whether they actually do it.
Right, your commitment, your plan.
Exactly. Your commitment or plan to, say, take your medication is the biggest indicator. And that intention is built on three key components. The first is attitude.
An attitude, that's basically your personal feeling about it, right? Positive or negative evaluation, like taking my medication is good for me, or maybe, changing my diet will be way too difficult.
Precisely. Then there's subjective norm. This is about the perceived social pressure.
Ah, what other people think.
Yeah, what you think important people in your life, like your family, friends, maybe your doctor expect you to do. So you might think, my family and doctor expect me to take my medication, so I feel I probably should.
Okay, attitude, social pressure.
Yeah,
What's the third one? Is it about whether I can actually do it?
that's exactly it.
Yeah.
It's perceived behavioral control, or PBC. This is your perception of how much control you have over performing the behavior.
Like, do I feel capable? Do I have the resources?
Right. Do you have the resources, the time, the opportunity? So thinking, I feel capable of managing my diet changes, or I actually have time to exercise like they told me to.
So the theory says these three things, attitude, subjective norm, and perceived behavioral control, they all feed into your intention.
Correct. And then that intention influences your actual behavior. But there's a nuance here. Perceived behavioral control can also have a direct influence on behavior, sometimes bypassing intention altogether.
How does that work?
Well, imagine you strongly intend to exercise, but then you suddenly feel physically unable, or, say, your gym is unexpectedly closed. Your perception of control, or lack thereof, directly impacts whether you actually do it, regardless of how strong your intention was moments before.
Ah, okay, like a practical override. Makes sense.
Yeah. And this model, the TPB, it's had a lot of success in the past. The source material points out it's been effective in predicting a whole range of health behaviors.
Like what?
Things like dietary choices, physical activity, condom use, even drug use, and health screening behaviors. So it's been a really useful tool in many different contexts.
So what's different about this particular meta-analysis then?
Well, what's fascinating here is that while TPB has been studied extensively, previous meta-analyses didn't specifically zero in on adherence behavior or, crucially, on adults with chronic illness.
Ah, okay.
This study really focuses on that critical group, giving us insights we didn't quite have synthesized in this way before.
And that feels like a really key distinction, doesn't it? Because adherence in chronic illness isn't just any old health behavior. It requires this very specific long-term commitment.
Absolutely. It's about performing behaviors consistently over a long period, often for life, to manage the disease based on professional recommendations. It's not like a one-off decision, deciding to get a flu shot this year.
Right. Can you give an example of that difference?
Sure. Think about someone just deciding to take up exercise for general fitness versus, say, a patient who needs to adhere strictly to a prescribed exercise plan after having a heart attack. The context, the motivation, the consequences, they're very different.
And the consequences of not adhering are higher too, presumably.
Much higher, typically. Non-adherence in chronic illness often leads to far more serious outcomes because the disease or symptoms can deteriorate pretty rapidly without that consistent management.
And the population itself is different from usual studies.
Yeah, the source material points out that typical TPB studies often use, well, young, healthy undergraduate students. Easy to recruit, I suppose.
Yeah.
But this meta-analysis specifically includes only adults diagnosed with a chronic illness. These individuals are often older and sometimes more socially disadvantaged, which are factors that could significantly influence how the theory actually plays out in the real world.
So they needed a robust way to test if the theory really held up in this specific context. You mentioned something called nomological validity.
Right. To really stress test the TPB, basically, the researchers used a statistical technique called path analysis. Sounds complicated, but it essentially lets you look at all the connections within the theory, attitude to intention, intention to behavior, PBC directly to behavior, etc., all at the same time.
Instead of piece by piece.
Exactly. It tests the whole network of relationships to see if it holds together empirically. They call this testing nomological validity. It's a rigorous approach, not always done in these kinds of reviews, but it's crucial for building really strong evidence.
Okay, so we've laid out the pieces, the huge problem of non-adherence, and this major theory, TPB, that tries to explain the why. Now, let's get to the core findings. What did this meta-analysis actually reveal about how well TPB works for chronic illness adherence?
All right, the big headlines. The meta-analysis found that the theory of planned behavior explained about a third, 33% of the variance in people's intention to adhere to their treatment.
Okay, a third of the intention. What about the actual behavior?
That's where it gets interesting. It explained only a fraction of that, just 9% of the variance in actual adherence behavior.
9%. That's a massive drop-off from 33% for intention.
It really is.
So people can have strong intentions. They can plan to do it, believe they should do it. But if only 9% of their actual action is explained by this theory, what on earth happens in that gap?
That's the million-dollar question, isn't it? This intention-behavior gap is really the crux of the challenge here.
It seems huge.
It is. It means we can get patients to want to adhere. They can have the strongest intentions based on attitudes and norms and feeling capable. But that desire, that plan, is surprisingly weak on its own in ensuring they actually do it consistently over time.
It really makes you pause. You can intend all you want.
But putting it into consistent action is another beast entirely, especially for something as demanding and long-term as managing chronic illness.
Okay, so given that major gap, let's look back at the intention part. Which factors were most strongly linked to someone forming the intention to adhere?
Well, the study did confirm that attitudes, subjective norms, and perceived behavioral control were all statistically significant predictors of intentions. That part holds up.
But was one stronger than others?
Yes. And here's where it gets really interesting for, say, designing interventions. Perceived behavioral control, or PBC, had by far the strongest effect on intentions.
The feeling of being capable.
Exactly. Patients' feeling of capability, their sense of control over doing the behavior, was the most powerful predictor of whether they intended to do it. And crucially, PBC also showed that direct, significant impact on whether the behavior actually happened, that shortcut we mentioned.
Wow. Okay, so if you're a healthcare provider or designing a health program, maybe the biggest lever isn't just persuading someone it's a good idea, but really empowering them, making them feel capable of managing it day to day.
That seems to be a major takeaway. That sense of self-efficacy, feeling like you can overcome barriers and actually do the steps required, that seems critical based on these findings.
And intention itself still predicted behavior, just less strongly.
Yes, intention was still a statistically significant predictor of behavior, but overall, the effect sizes, the strength of these relationships were generally lower in this chronic illness context compared to what other meta-analyses found for TPB in different health behaviors.
So TPB seems a bit less powerful for predicting long-term adherence in chronic illness than for maybe, I don't know, deciding to use sunscreen.
That's one way to put it, yeah. The long-term, complex nature seems to dilute the predictive power somewhat. And adding to that complexity, the study also found what they called considerable heterogeneity across the studies they analyzed.
Heterogeneity, meaning lots of variation.
Exactly. A high degree of variability between the individual studies included. So while the general trends of TPB predicting intention and behavior hold, how strongly they hold varies quite a bit depending on the specific illness, the patient group, the type of adherence behavior, the way it was measured.
So it's messy.
It's messy. Adherence behavior is incredibly complex and context-dependent. This variability makes the overall average findings, like that 9% for behavior, a bit less precise. But it's also an important finding in itself. It tells us there's no single magic bullet explanation or intervention.
Okay. Now, what about things that might explain some of that variation? Did the type of behavior matter? Like, is adhering to medication different from adhering to diet or exercise, according to TPB?
You'd think so, wouldn't you? But surprisingly, the researchers looked at that medication, exercise, diet, general self-care, and they found considerable consistency. No significant differences in how the TPB relationships worked across those different behavior types.
Really? That's genuinely counterintuitive to me. Taking a pill feels very different from changing your whole diet.
It is surprising, and it does contrast with some earlier research. The authors of this meta-analysis floated an idea that perhaps it's because all these behaviors, in the specific context of managing chronic illness, involve active engagement. They all require conscious effort, planning, and ongoing management from the patient.
Okay. So maybe the underlying psychological process has similarities despite the outward difference. What about how adherence was measured? Self-report versus something objective like pill counts or monitors?
They looked at that too. And again, perhaps surprisingly, no significant differences were identified between studies using self-report versus objective measures.
Interesting. Although
it's really important to note that the vast majority of studies did use self-report. And self-report, well, it can be subject to bias, right? People might overestimate how well they're doing, maybe unconsciously or just to present themselves well. So that could inflate the adherence levels reported.
good point. And demographics, age, gender, did those make a difference?
Mostly no. They largely didn't significantly moderate the effects. There was one minor effect of age on the relationship between subjective norm and perceived behavioral control. But overall, demographics didn't seem to explain much of that variability we talked about.
Okay, let's circle back to that massive intention-behavior gap. It really feels like the elephant in the room for TPB. What are the main criticisms of the theory that might help explain why intention doesn't translate better into action, especially for chronic illness?
Yeah, that gap really highlights some well-known criticisms of the TPB. One is that critics often call it a static model,
Meaning it doesn't change.
meaning it doesn't fully capture how our past behavior influences our future thoughts and intentions. For instance, if I manage to stick to my diet for a week, that success might make me feel more capable, boosting my PVC and strengthen my intention to continue. The theory doesn't always explicitly map out those feedback loops, although Ozen, the creator, argues it can be interpreted dynamically.
Okay. What else? I remember reading it's very rational.
Yes, that's another major critique. The TPB focuses heavily on conscious, rational thought processes, weighing pros and cons, considering social pressure, assessing capability. Critics argue it often overlooks or downplays the role of emotions, habits, and non-conscious or implicit influences.
Good cravings or just forgetting.
Exactly. Things that aren't necessarily neat, rational decisions, but can strongly drive behavior. And then there are measurement challenges. Just the practical difficulty of measuring these things accurately. Plus, the time lag between measuring someone's intention and then measuring their actual behavior can weaken the prediction. For chronic illness adherence, which happens over months or years, this is a big deal. The longer the gap, generally, the weaker the link between the initial intention and the final behavior.
And what about limitations of this specific meta-analysis itself? You mentioned the heterogeneity.
Right, that high variability across the included studies is a key limitation. It reduces the precision of those overall average effect sizes we discussed. And like any meta-analysis, there's always the potential for publication bias.
Meaning studies that find strong results get published, but ones that find nothing don't.
Pretty much. Studies showing TPB works well might be more likely to see the light of day than studies showing it doesn't predict adherence very well. That could skew the overall picture presented in the literature that the meta-analysis is based on.
So, taking all this together, it sounds like TPB is useful, it gives us some understanding, but it's definitely not the whole story for chronic illness adherence.
That seems to be the conclusion, yes. It raises an important question. While the theory of planned behavior certainly makes a useful contribution, the findings strongly suggest that focusing solely on its variables, attitude, norms, control to predict adherence or design interventions might be insufficient. We're likely missing key pieces of the puzzle.
So, if TPB isn't enough, what else do researchers suggest we need to look at to get a better grip on adherence?
Well, one idea discussed in the meta-analysis is potentially adding more predictors to the basic TPB model to try and close that intention-behavior gap.
Like what kind of predictors?
They specifically mention factors like patients' beliefs about how necessary their treatment actually is, and also patients' concerns about their treatment regime, like worries about side effects.
Ah, the necessity concerns idea.
Exactly. Other research, particularly around medication adherence, has shown these beliefs can be really powerful predictors. If you don't truly believe you need the medication or you're deeply worried about taking it, that can override a generally positive attitude or intention.
Makes sense. Are there entirely different models people are looking at beyond just tweaking TPB?
Absolutely. Researchers are exploring alternative, potentially more comprehensive models. One gaining traction is the Capability, Opportunity, Motivation, and Behavior Model, or COMB.
COMB, what does that cover?
It tries to integrate a broader range of factors. Capability includes psychological and physical capacity. Opportunity covers physical and social environment. And motivation includes reflective thought processes like TPB, but also automatic or habitual responses. It aims for a more holistic view.
Interesting. Any others?
There are also models developed very specifically for medication adherence, like that necessity concerns framework we just touched on, which really drills down into those core patient beliefs about their medicines.
So clearly, understanding adherence is complex. What about improving it? Developing effective interventions sounds like the ultimate goal, but is it working?
Yeah, it's the massive challenge, isn't it? The meta-analysis touches on this. Developing effective adherence interventions is a huge priority, but it's tough.
How tough?
Well, the source mentions a big Cochrane systematic review that looked at interventions for enhancing medication adherence. The results were pretty inconsistent.
Not great.
Not ideal. Very few high-quality studies managed to show significant improvements in both adherence and actual clinical outcomes, like improved health. The interventions themselves were incredibly varied, making it hard to pinpoint exactly what works best, although things like frequent patient interaction and finding ways to simplify complex regimens seemed promising.
Okay, so let's try to wrap up this deep dive. The big takeaway seems to be that while the theory of planned behavior gives us a valuable way to understand why people intend to follow treatments for chronic illness.
There's a significant, persistent intention behavior gap.
Right. It's definitely a crucial piece of the puzzle, explaining things like attitude and perceived control, but it's clearly not the whole picture when it comes to getting people to stick with treatments consistently long term.
And hopefully this deep dive gives you, the listener, a much better grasp of the complexities involved in this really crucial area of health behavior.
Yeah, whether you happen to be a healthcare professional or maybe a patient managing a condition yourself, or perhaps you're just, insanely curious about human behavior.
Understanding these dynamics is pretty vital if we want to better support people's health journeys.
So what does this all mean then? Given these complexities, especially that stubborn intention behavior gap, maybe here's something to think about. If simply knowing what you should do, and even intending to do it, isn't enough, what deeper factors might be missing?
Yeah, what other elements, maybe less conscious psychological factors or aspects of our environment or habits, what do you think are the missing keys needed to truly unlock consistent healthy behavior, especially when it's hard?
Definitely something to chew on. Think about how this impacts your own understanding of behavior change, or maybe the practical implications for improving health in your own life or even in your community.